All right, good afternoon. I've been tasked with describing whether resting indices suffice for coronary physiology. And it's a great topic for a debate because, right now the European guidelines place IFR and FFR at equal footing with a 1A recommendation, whereas the American guidelines still prefer FFR as the gold standard. I get these debates all the time with Dr. Curran, who also supports FFR as the gold standard. Trying to get these slides to advance. Okay, so invasive translesion pressure measurements, FFR is founded on the theory that flow is related to pressure, or pressure indices can approximate flow only at maximal hyperemia, when microvascular resistance is minimized and flow is maximized. We now have resting ratios, however, that purport to say that in the diastolic period, you can get a PDPA, or a pressure ratio, that has a relative minimum and sufficient flow to create a gradient of pressure and flow relationship as well. And the question becomes, is that accurate? Can you believe it? And what is the data supporting that? We know that the IFR tends to correlate with the FFR in a modest ratio, about 80 to 85% categorization match. The R value is only 0.66, and so the question has always been raised, well, what about these discordant findings? What do you do with this discordant data? And I'll go over that in a second. But regardless of whether they correlate or not, the DEFINE-FLAIR and IFR-Swedeheart studies tried to attempt to describe whether revascularization guided by IFR could be equivalent to FFR, using a cutoff of 0.89 for IFR and 0.80 for FFR. They randomized them to either FFR-guided revascularization or IFR-guided revascularization, and you couldn't do the other modality. And we still are in 2-year follow-up for this study, but the composite of MACE was death, MI, or unplanned revascularization, with a non-inferiority margin for a risk difference of 3.4%. And by now you're all familiar with the outcome of these two studies. In 4,500 patients across these two studies, the DEFINE-FLAIR showed a non-inferior hazard ratio of 0.95, and IFR-Swedeheart had a hazard ratio of 1.12. So you had non-inferior clinical outcomes, what we really care about, despite having differences in how to measure pressure ratios. So the question is posed, if IFR is only a moderately good estimator of FFR, why does it have non-inferior outcomes? Well, if you're an FFR advocate, you might say that, well, clinical events are a poor marker for ischemia. Ischemia, FFR is a gold standard for ischemia, and clinical events are just too crude, they're too few in number. Maybe the non-inferiority margin was too large, and maybe if you had a study of 50,000 patients, it would have been different. Maybe PCI as a treatment is not perfect. Patients don't take their drugs, their medications afterwards. Patients are always having their comorbidities. But I would submit to you that perhaps FFR is not a perfect test for ischemia, and that IFR can match its performance in clinical care. My opponent, Dr. Hakim, is going to argue that there's not enough data for IFR compared to FFR. There's many more studies with FFR. But when you actually look at the data, the numbers of patients included in the DEFINE-FLAIR and IFR-Swedeheart trials actually outnumber the total number of patients enrolled in the FFR versus coronary angiography trials, and such that this network meta-analysis makes it very clear that the point estimate for the odds ratio is exactly the same at 0.70 and 0.73 for FFR versus IFR. We also look at these discordances, and is there any evidence that these discordances are concerning? Well, there's really no clinical evidence yet on that there's any harm when you have an FFR that's positive and a IFR that's normal. So the 3-vessel FFR Friends study from a Korean registry took 821 deferred lesions, and they found that 8.8% of lesions were discordant, and only the patients that had concordantly abnormal FFR and IFR were actually had a clinical event. If you had only positive in one or the other, you didn't have any events any more than the reference. This was similar to data from Echevarria-Pinto, where they found that there's no harm if you had FFR abnormal but PDPA that was normal. And so only when they were both abnormal was there a significant increase in MACE. So there's no difference in clinical outcomes unless both were positive. And then when you compare IFR, the PDPA, against any other non-invasive test, whether it's a nuclear stress test or a PET-derived CFR, even invasive tests like HSR and invasive Doppler CFR, if you take any other external standard for ischemia, there's actually very little difference between these ratios, and that they perform adequately. Everything is 80%, as Dr. Curran likes to say. They all correlate moderately well at 80%. My opponent may argue that there's no good theoretical basis for IFR because, even though there's a relative minimum of pressure, we know that if you give adenosine, the IFR ratio actually declines further. So what is really the rationale? It's not a true maximal hyperemia. It's only a relative. Reduction in the macrovascular resistance. So increasingly, our European colleagues have described the theoretical basis for IFRs is a little different from what they might have thought originally. What we think now is happening is that the coronary artery is trying to maintain coronary flow ratios or flow rates across a large range of stenoses. And it does so at the cost of losing pressure. So even though at the bottom, the column on row C, there's normal coronary flow until you get to an IFR of 0.81, that's coming at the cost of maximal more and more vasodilatation of the microvasculature. And this is evident in terms of pressure. So on the right here, you see hyperemic conditions. This is Gould's classic drawings, which suggested that you can only have a flow curve that differentiates across moderate stenoses when you cause hyperemia and abolishes autoregulation. On the left-hand side, though, is the new concept of actually measuring that degree of autoregulation. So in other words, coronary flow is maintained and flat between 50 to 85% diameter stenosis, but it comes at the cost of a pressure gradient and a drop in microvascular resistance. And so what evidence do we have that this type of curve actually exists? Well, we do have data from the IDEAL study, which took 567 patients, and they found that there actually is a relationship between pressure and flow, even in the absence of hyperemia. You can measure the changes in pressure, and that reflects the changes not in flow, but of microvascular resistance. So that change in microvascular resistance is a reflection of how severe that epicardial stenosis really is. And so this is the theoretical basis for IFR. FFR may actually overestimate stenosis severity in some cases. Patients with severe stenoses might have a CFR that increases, a CFR with hyperemia that only increases to 1.7 instead of 1. But in patients with mild stenosis, you might have an exaggerated response where the CFR is 3.2. And what evidence do we have that this actually exists? So in other words, you took a mild stenosis and you made it look positive with an FFR of 0.73 in this case. This case presented by Cook shows a circumflex lesion that has an IFR of 0.92 and FFR of 0.77. We see this not infrequently. But when you measure actually with CFR, which is the standard, the CFR was 2.7. And so this reflects adequate flow and in fact an exaggerated flow response. And if you took 567 patients, they found that FFR positive lesions with IFR negative actually correlated better with the normal unobstructed vessel than the people who had IFR positive and FFR negative. So this suggests that there's a concern that FFR may actually overestimate stenosis and actually lead to unnecessary stenting. So the treatment allocation from the DEFINE-FLAIR and IFR-Swedeheart trials, there was reduction in PCI based on IFR interrogation, and the concern would be that maybe some of these are actually unnecessary. So some limitations to FFR, there's variable responses to adenosine, microvascular disease, caffeine may inhibit your adenosine response, and serial lesions are a little difficult to work with. When you work with resting indices, you have fewer adverse responses to adenosine. We're familiar with those. And then the cost effectiveness of the IFR and resting ratios has been shown to be positive by having a reduction in cost of $900 a year by shortening procedure time, avoidance of hyperemic agents, and fewer unnecessary PCI procedures, and a reduction in readmissions due to recurrent PCI or CABG. I think the biggest value for these resting ratios are with these pullbacks, where you can actually get a calibration of where these lesions are and where the stenosis gradient is greatest, and you can get a prediction for what you'll do with your stent. So in this example here, you can identify the coronary lesion in the LAD, and even despite overlap, identify where the lesion will be best treated. And in the bifurcation lesion in the ramus, you can tell that by treating the lower branch of the ramus, you'd actually have a better response than treating the upper branch of the ramus. And sure enough, that was the case. So the take-home points are that resting ratios are non-inferior to FFR in every clinical outcome study to date. Resting ratios are similar to FFR compared with any external ischemia standard. And resting ratios are easier, faster, cause fewer symptoms, save money, and are better with serial lesions and more predictable post-PCI. And if you could only have one thing, a non-hyperemic pressure ratio or FFR, which would you choose if you're on a desert island? And I would say that the non-hyperemic pressure ratio is sufficient. Thank you.